And about the sound.
Good afternoon, distinguished colleagues. Allow me to welcome you here. This is room 2, and we have a breakout symposium which brought together international speakers on issues of management of patients with COVID-19. As of today, COVID-19 was and continues to be one of the most urgent issues in working with such patients. We must understand that we have had COVID-19 for 20 months, and during those 20 months, we have had a new cohort of patients who suffer in the post-COVID period from complications caused by COVID-19. All speakers have gotten connected, and I would like to give the floor to Valery Shustov, who will be talking on the first issues of managing people in the post-COVID-19. How long do antibodies persist after COVID-19? How long does a patient have antibodies? How long this person can vaccinated or not vaccinated after COVID-19? Valery, the floor is yours. Thank you very much. I will try to present my presentation entitled How Long Do Antibodies Persist After COVID-19 Infection? I will show you the results of several scientific researchers. Will analyze the situation. If there are any questions, I'll be more than happy to answer them. I think everyone knows and monitors the situation with COVID-19. You can see the incidence rate in the world and the growth of the incidence rate. Right now, there is the fourth surge of the disease globally. Actually, 20 months have already passed since the outbreak of this disease, since the start of the pandemic. We have already learned how to properly diagnose the disease, partially how to treat the disease, but there are still a lot of unknowns as far as COVID-19 is concerned. This presentation is educational, and I would like to answer the question, how long do antibodies persist after the disease? In Moscow, the herd immunity was developed well in May 2020. There was a mass screening for antibodies. We still continue screening for antibodies, as you can see it here. Here you can see the results obtained in our lab, the screening of our patients in the lab. And you can see that IgM detection goes down slowly but surely. However, the concomitant detection of IgG and IgG is an up and down in its nature, depending on the growth of the number of people who contracted COVID-19 or vice versa, reduction of such people. Unfortunately, we see a slow growth, but we can see more cases with the detected IgG. Starting from 2021, we had 60% of all cases from the patients tested during the month. So 60% of patients had antibodies to IgG. The first analysis I would like to start with is 7-month kinetics of SARS-CoV-2 antibodies and the role of pre-existing antibodies to human coronaviruses. This work was performed by our colleagues in Spain. That was the analysis of 235 samples, 76 patients with COVID-19. Well, and you can see 235 blood samples obtained from those 76 patients. This study was conducted using Luminex method, and that's a very interesting technique with a very high specificity and sensitivity, and to some extent, it is even better than ELISA, but unfortunately, Luminex is more expensive as compared to ELISA or some other diagnostic methods. So let's look at the kinetics of antibodies of IgA and IgM. The Spanish researchers conducted to carry out the study of antibodies to different epitopes such as N protein, RBD, S1, S2, and S proteins. And if you look at the entire trend of detection of IgA, you can see that after 230 days, 69% of people had IgA antibodies. Well, also antibodies to RBD, S1, and S2. As for antibodies to N immunoglobulin after 50 days, well, the antibodies practically disappeared. As for IgM, the situation is slightly different. We can see first and foremost that the peak of the growth of antibodies to titers, well, titers of IgM and IgA after the disease. Well, we can see that there is a slow drop in the number of antibodies. After 200 days, only 34% of patients had antibodies to IgM. So that was 1 in 3 patients, had antibodies detected after 7 months following the disease. Now let's look at the kinetics of antibodies to IgG. Here the situation is different. We can see that only after 50 days, there was, or let's put it this way, there was the peak of IgG to such antigens as RBD, S1, and S2. However, if we look at IgG to the antigen of the N protein, here we can see that after 50 days, there was a peak, and then there was a gradual decline. Thus, as for N protein, only 26% after 200 days had antibodies to this protein. As for S1, and S2 proteins, 71% had antibodies after 6 months following the disease. Now I'd like to show you the results of the work conducted by our Chinese colleagues. They have already analyzed the situation a year later after the first symptoms of COVID-19, and you can see declining levels of neutralizing antibodies to the coronavirus. They had 76 patients included in the study, 35 men, 41 women. The average age is 60 years. And you can see the first graph obtained by our Chinese colleagues, seropositivity out of all patients. So you can see the number of patients who had antibodies in this or that period, 2 months after the disease, IgM, anti-NIgM were in 50% of patients with, as for anti-NIgG, well, that was in all patients. Well, you can see here that in time, like 4 months later, 6 months later, there was a reduction in the number of patients with IgM. However, a year later, we still have a share of patients who have antibodies to IgM, and that's interesting and partially bizarre. But nevertheless, these are the results. 5.3% of patients a year after the disease still had antibodies to IgM detected. As for IgG, well, you can see here that the share of positive patients in terms of antibodies to IgG remained the same, or there was a minor decline, like from 90 to 88%. Well, then the authors of the study assessed the dynamics of the titers of specific antibodies. Here you can see that according to the results of the study, changes in the titers of IgM and IgN to S and N protein, we can see there was a drop in the titer below the threshold meaning, as you can see it here. And of course, this cannot be said about anti-S-IgG. Anti-S-IgG, well, it drops in time. Well, also anti-N-IgG drops in time, but during the last 4 months, the difference between the titers is basically muted. That means that the titers drop so slowly, or the immunoglobulin G decay is so slow that the titers still persisted, but the results obtained by our Chinese colleagues are very interesting. Here you can see the specific neutralizing activity, which was neutralized by our colleagues in China, and the results are very interesting here. This neutralizing activity was measured in 73% of patients, and you can see that after 1 year, you can see that 57% of patients had no neutralizing activity. That means we still have detect IgG to the protein, but the neutralizing activity is basically lost. Yes, so we have quite a few patients who still have neutralizing activity. Their antibodies can still neutralize the virus. However, their share is not very significant. 5.5% still have a maximum titer of virus neutralizing antibodies after 1 year following the disease. Now I'd like to show you the results of the studies conducted by our Chinese colleagues in Wuhan, who examined their patients, blood donors to antibodies to IgG and RBD. We know that RBD is right now the most close type of antibodies to neutralizing antibodies. You can see the entire cohort of patients is shown here, 869 donors, and these donors had 1,782 plasma samples examined. Well, you can see 391 females, 478 males. The average age is 38. The method used is very well known. It's ELISA, and in particular, it was the ELISA sandwich method, so that we could accept these results and compare them with the virus neutralizing antibodies. The researchers analyzed the correlation between virus neutralizing antibodies and IBD, IgG titers used in ELISA. We can see that the correlation was quite good, so we can continue using this test system, this assay, and use the results obtained. In time, well, or let's put it this way, that was the time period of 12 months. In this study, they divided this period into 3 stages. Stage 1 is the early stage, when during the first 2 months following the onset of the disease, the middle stage, 6 months after the disease, and 11 to 12 months, so the late stage. And here you can see the seroprevalence. When the early stage, it's 94.6% of the total number of patients. Well, as you can see it here, 89.4 and 81.2 at the late stage. Well, also at the initial stage, 5.4% of donors had the lower level of antibodies than the threshold level. That means 5% of the population either did not have antibodies developed, or the sensitivity of the test system was low. That's another explanation. And the test system had not enough sensitivity to detect antibodies in this group of patients. Then the researchers analyzed the dynamics of patients with high titers of IgG to RBD SARS-CoV-2, and you can see what the situation is. The patients were divided into 3 groups. The first, well, the negative group, well, you can see it's 1 to 80, and you can see that's negative 1 to 80 to 160 low, 132, 1 to 320, 1 to 640, moderate 1 to 1,280 and higher. That's the high levels of titers. Well, at the initial stage, the high titers or moderate titers were in 73% of patients, 73% of donors. However, 6 months later, the share dropped to 41.3%. And by the end of the follow-up period, it was 27%. So we can see the trend toward a decline in the titer. But if we look at the share of negative patients with negative titers, well, you can see it is growing in time. Following that, the researchers calculated the average geometric titers over a particular time. Well, you can see that was done for each month. And let me remind you that this is one of the ways that can detect the immunity strain of the population. And as in the previous study, we can see that there is a decline in the titers of immunoglobulin G, but here you can see another interesting moment. After month 9, you can see there is a kind of stabilization in the decline of the antibodies. So you can see at day 200, well, the titers do not start declining significantly, but the general trend is that during the 12-month period, there was a reduction by around 70%. In order to assess the stability of titers RBD IgG, the researchers analyzed the blood of 237 donors at the initial stage and at the late stage of the study. At the initial stage, donors were divided into those who had high titers, intermediate titers, or low titers. 12 months later, you can see that 51% of patients who originally had low titers of antibodies. Half of them had no antibodies detected at all. Half of the patients, in the patients with the middle titers or high titers of antibodies, well, there was a reduction by 1 log in the number of patients who had first middle titers, and by 54%, there was a drop from high to middle in those patients. Then there was the analysis of the gender aspects on changes of RBD-IgG. At the initial stage, there was a difference between male and female patients. Male patients are marked in blue, female in pink, but 6 or 7 months later, or 11 to 12 months later, well, the difference basically doesn't exist. Yes, at the initial stage, well, we can see that men have a higher risk of the disease. We know that the mortality rate is higher among men as compared to the situation among women, but a year later, the situation is basically the same. Also, the aspect of age and the influence of age on changes of RBD, IgG titer, and there was the positive correlation with the plasma donors, as you can see, with age. Well, you can see, well, the increase of the titers and the decrease of the titers. Well, so what conclusions can be drawn as a result of this? IgM can circulate in blood for more than 1 year. Well, RBD IgG antibodies can persist in more than 70% of patients after COVID-19. And during a 12-month period, there is a decline of RBD IgG titers by around 70%. There is a stabilization of RBD IgG titer after 9 months. Following COVID-19, many researchers still continue to study this phenomenon, why this is happening, and how fast the titers decline. Also, there are high RBD IgG titers after the disease, and in this case, they persist in blood for a longer period of time. Well, let me thank you for your kind attention, and colleagues, friends, I hope that we all understand that immunization is one of the key aspects to reduce the spread of the coronavirus infection. Thank you very much. Valerie, thank you very much indeed for this presentation. And let me say that you already got a barrage of different questions. We were inundated with different questions. We'll ask you questions at the end of the symposium, but let me just voice some of the questions. How can you account the long persistence of IgM? Also, how can you account for the difference in the test systems to IgG? It's 15, 50, and 70, depending on the system. That's the cutoff. There also the question about the visibility of N protein detection and immunity to it. Unfortunately, the picture has gone. I hope Valerie can still hear me. Valerie, are you with us? If you're with us, say something. Valerie, can you hear us? Unfortunately, yes, I can hear you. All right, now we can hear your voice. Terrific. Well, the next question concerns the visibility of detecting N protein, because N protein appears only when there is the reproduction of the virus, and there are questions related to immunization and the correlation of the antibody level and the need of immunization. If we cannot just rely on the virus neutralizing activity of these antibodies, they persisted, but they may not be neutralizing, then there is no need to determine these antibodies for immunization. So, but let's move on with our agenda. Let me just say that our program is unique. The symposium is unique because it is devoted to what is happening after COVID-19. And the first question is, what is happening to antibodies? Should we get vaccinated? Also, what consequences can we expect? And the next three presentations will be devoted to such consequences. That is why we have international experts present here. They will answer such questions as a CHF in the post-COVID period, post-COVID as a new risk category, CKD in the post-COVID period. But let me now make my own presentation. Please share the screen, and I will be talking about long-term COVID-19 consequences. So, dear colleagues, we have had COVID-19 for 20 months. We know there have been a lot of studies related to hospitalization due to COVID-19, interleukin-1, interleukin-6, also JAK kinase inhibitors. We know that there are a lot of studies related to glucocorticosteroids with the high level of evidence. But what about the post-COVID period? A lot of documents have been published, but they just contain general information. Let's just be more specific regarding what is happening with the patient in the long COVID-19 period. Well, when the post-COVID period takes place, there are different classifications regarding what is meant by the post-COVID period, but we say that the patient recovered, but the disease is still on. What questions do we need to cover? First of all, we need to determine how long the symptoms persist. The patient was discharged, the patient is at home, he has no therapy, but the symptoms persist. As for the WHO, they say that, symptoms persist starting from early periods. We're talking about weakness, shortness of breath, tachycardia, accelerated heartbeat, but only, we had 2,113 people. It's not enough to say that symptoms persist. As for large-scale studies, when patients were monitored for 7 months, I should say that 7 months is practically the ceiling of all those observations we've had. Sometimes in one case, it was at 12 months, and that's our registry active. It's for 12 months, but in any case, most cases, had 7 months. By 7 months, we can have a reduction of symptoms and the persistence of some symptoms. First of all, cardiovascular symptoms persist. We're talking about accelerated heartbeat, heartburn, chest tightness. It's due to the damage to the cardiovascular system, pericarditis and sarcoiditis that patients can have in such situations. But these symptoms are significant. Patients can have a weakness, shortness of breath. They basically decline by the 6th month. But you can see, hypertension persists, and there is a new category of people with hypertension. Let's see what is happening when patients come to see the doctor. Ambulatory assistance, you can see, the level is a little bit higher. Number of hospitalizations are the same. Emergency care is the same. So month 3 and month 6 are important for patients in terms of turning for medical help. If we look at the reasons for medical care or seeing a doctor, it's hypertension, which ranks 1. As for visits for ischemic heart disease or GI pathology, that's basically the same level on month 3 and 6, and loss of glycemic control, aggressive therapy with glucocorticosteroids. Unfortunately, the infectious process lead to the destabilization of glycemic control. You cannot return to the previous regimen schemes, and diabetics after month 6. I'm not showing you data for 12 months. We already have this data. We are just processing them. And this data shows that diabetics come to see a doctor because they cannot control glycemia, just like people with hypertension. Well, this slide is very populated, but let's focus on cardiovascular pathologies. If we look at cardiovascular symptoms, we can see that large-scale international trials, and that's the review published in one of the medical journals. Well, this data coincide with our data. The symptoms appeared, they grew, and they did not disappear. Well, here it's a 7-month follow-up period. In our study, it's a 6-month follow-up period. Are there grounds that the symptoms will disappear after 12 months? The answer is no. That's a new category of patients. They have new diagnosis, and we've been talking about that for the second consecutive day. Any practitioner must remember that. What diseases do patients have? Hypertension, yes, by month 6, there are more cases like this. Ischemic heart disease, yes, there are 2.5 times more cases like this by month 6. Well, that is the answer to the question. Well, microthrombosis of capillaries, well, 240 million people who have had COVID-19. Unfortunately, now in the high-risk group, it will be difficult to work with them. And of course, atrial fibrillation. But let's compare with the population data. These are the Russian data. Well, that's the prevalence rate in the population. Blue bar, 3 months, a red bar, 6 months. Can we say that these are the same patients? No, we understand it perfectly well that by month 6, the increase in the number of such diagnoses is 2.5 times higher as in the general population. So a person with 40, 45 years old with atherosclerosis with COVID-19 had the 2.5 times higher chance to have an ischemic heart disease after COVID-19. Here you can see the long-term consequences. The same is true of hypertension and coronary heart disease. And who are those patients who had the new diagnosis? What is the difference between these patients at the hospitalization stage as compared to other patients? Maybe they had severe diseases. Yes, that's true. There's no direct correlation here. And the dear experts who are present at this symposium or at the expert council, well, we mentioned this fact that there is no direct correlation. We understand that a patient who had a severe disease has more chances for a new disease. And here there is a high risk of thrombosis and other complications. If new diseases did not develop, probably the patient will reconvalesce. And here you can see this indirect correlation through the development of new diseases. But let's move on. And now we can focus on cardiovascular diseases. They stem from what I have already mentioned. Post-COVID is linked to cardiovascular pathologies. If we look at the analysis of symptoms in the post-COVID period in patients with and without cardiovascular diseases, you can see that when the patient was hospitalized, he had the cardiovascular pathology, and any symptoms will increase in this case 3 to 4 times as compared to the general population. Especially this is true of month 6. If we look at the situation when people come to see a doctor, all these patients with cardiovascular pathology lost control of their disease. AF, well, paroxysmal AF, the need of additional anticoagulants, well, chest pain, hypertension, well, patients can't control blood pressure, and dyslipidemia is also more significant. If we look at the regimens, there have been changes there. You can see the higher frequency rate in the post-COVID period, particularly by month 6 of the administrations of sartans, beta blockers in the middle. Well, these drugs are administered more often. Statins, well, bar number 4, and finally DOACs. There has been an increase in the administration of such drugs by a factor of 4. Well, we can say, yes, we treated these patients with anticoagulants after the discharge from the hospital. We discussed this in the morning. In Eurasia, well, they administered DOACs without any evidence-based data, but now there was the famous Michel study, which put a period of the question of whether DOACs should be administered in the post-COVID period. The answer is yes. That's a randomized clinical trial, and well, rivaroxaban was compared with placebo, and the dose was 10 milligrams, and in the head-to-head study on a significant population, well, you can see a 67% difference in the number of episodes of thrombosis. So if a patient was on a DOAC after discharge, well, the situation will be much better in terms of a lesser number of thrombosis and thromboembolic events. We understand it perfectly well that these patients were more severe. These patients needed a longer period of hospitalization because they had different risk factors. And it's true that even without any evidence, DOACs were administered to such patients, and this study fully confirmed this. Especially from one point of view, we can reduce the risks in the long-term post-COVID period. We understand that the administration of such drugs reduced the number of thrombotic events within a 35-day period after discharge and in later periods. As for the odds ratio, you can see that, well, there are more reliable information, less reliable information. You can see the situation with the anti-aggregant therapy. Well, if an anti-aggregant was added, well, the reliability dropped because we just had the rational use of drugs, and this had an impact on the patient during the year. What is the probability of death of the patient during the year? The probability is rather high. We know that during 6 months, every third death was due to cardiovascular diseases. There were also embolic events. We know that these patients died also from the decompensation of heart failure and because of the debut of the coronary heart disease. So we say that we have a patient and cardiovascular diseases. Even if they didn't have such diseases during COVID-19, they will have cardiovascular diseases later, depending on the risk factors, whether it's age or obesity or high BMI. Usually high BMI leads to the development of cardiovascular diseases, or the presence of 3 or 4 concomitant diseases led to poor prognosis in the post-hospital period. Why am I showing you this slide? So when you manage patients right after COVID-19, A, anticoagulants are a must if the patient is in the risk group. B, we can say, judging by the slide, you can take a picture of it, the more points you have on your patient's chart, and here, the higher the probability of death in the long-term period or the development of a new disease. Unfortunately, that is so. And finally, the question of immunization. We have already talked about that partially. You know that the expert council took place on May 18th, 2021, and at that time, no one thought about the mandatory vaccination about after COVID-19, but experts in 13 countries marked here made the same conclusions. Well, the first definition is 30 to 45 days after the first negative PCR. That's the peak of IgG. Then do the same test every 3 months, and 6 months is the threshold for making a decision regarding immunization. And Valerie will make a comment during the Q&A session how to assess the level of antibodies if it doesn't correlate with viral neutralizing activity. But this will be later during the Q&A session. In conclusion, I would like to say that COVID-19 opened up a new era for medicine. I think that all practitioners will agree these are different patients, and we will be discussing all these issues from this particular angle. The European Association of Therapists is paying a lot of attention to this. Follow our news. We'll be updating all the information on a regular basis. My presentation is over. Thank you very much. And now I'd like to give the floor to the next presenter. let's move on. And right now, the importance of cardiovascular pathology is of great importance. Now, Bojan Vertovic will be speaking from Ljubljana, Slovenia. He is head of heart failure at the university in Ljubljana, and he will be talking about CHF in the post-COVID period. As soon as Professor Vertovic is ready, I will give you the floor. Well, I can see you're ready, please.
Yes, thank you for your kind invitation. I would like to, first of all, share the screen here. And then my task today is really to talk about chronic heart failure. The idea is really, we have seen these maps here really many times before. This is one of the most recent ones since September 24th. So it actually shows the number of cases, the COVID cases, and and we know it's also a global epidemic. This is nothing new, really. However, this is again a similar map now of heart failure prevalence in the world. So it has to be emphasized that people with heart failure, there's more than 60 million people living with heart failure everywhere. And you can see here the estimates of prevalence of heart failure here. And you can see that the prevalence may be pretty high in some countries like Germany, for example, and also in the US. So it's a global pandemic as well. So what we're facing is really, the combination of two global pandemics, which may be something that's very difficult to manage. Furthermore, when you can see heart failure, those are the data before COVID. So before COVID, you can see that actually the number of patients with heart failure is increasing with the elderly population. And we also see the same trends in the COVID patients. So this is pretty much a similar trend we're having in heart failure and in post-COVID population. So this is something that may work together. Again, we can see that there is a big number of patients elder than 60 years of age. It's more than 5%, up to 13 even. So this is a lot. This is really a big number of patients. So this is the estimates of new cases of heart failure. You can see here the projected cases here. And these are the actual cases. Again, this is before COVID. So now I guess we're here and this is going to get even worse. So the projections of numbers of patients with heart failure were wrong. Why is the heart failure incidence increasing? First of all, because of the aging of the population. There is more ischemic heart disease, hypertension, and of course, many people survive myocardial infarctions and therefore they have a chance to develop heart failure. So having said this, you can see that heart failure per se is a growing disease even without COVID. But now we have a combination of COVID epidemic and then we have heart failure. So what I'm trying to present here is really how these two mechanisms may interact here. And there are actually two ways. So as you can see before, there may be de novo heart failure because of COVID, or it can be a decompensation of pre-existing chronic heart failure because of COVID infection, is similar to, let's say, any other infection that can also worsen heart failure. So if we first look at de novo heart failure because of COVID, we know that actually there is a viral response phase first, which is followed by the inflammatory response phase, which is exactly the phase which is dangerous for developing heart failure. So usually if you do not have heart failure before, in the early days of COVID infection, you do not develop heart failure immediately. As you can see on this slide here, it actually starts at day 21, and this is the risk period actually for increasing risk of heart failure. And it can be seen by increased anti-proBNP levels and increased troponin levels. So this is the place where we should be, paying attention whether or not there is a development of de novo heart failure. So why exactly does de novo heart failure develop? There are many mechanisms. You can just simplify this because of the hyperinflammation. This is, of course, an inflammatory stage. It's a virus that's actually very dangerous directly because of the inflammation. And the second thing is, of course, the coronary microvascular thrombosis and endothelitis, which is something that needs to be taken care of also. So those are the putative mechanisms. But if you see, actually, there was one study trying to see whether or not patients, when they have COVID, have differences with regards to their heart function and heart structure as compared to healthy controls here and risk factor match controls. So you can see here that those were the two groups that were really matched with regards to hypercholesterolemia, diabetes, hypertension, BMI, and they did MRI. And those were the data here. So you can see cardiac MRI, even though the patients were matched with regard to risk factors, has shown lower ejection fraction. And importantly, a lot of abnormalities in the MRI, pretty much in every index. You know, this has been significant. Everything here was significant as compared to healthy individuals, of course, and even for the ones matched for risk factors. This was further corroborated by the data from autopsies. So those are the cardiovascular findings, the histological cardiovascular findings. And you can also see that there is inflammation going on and a lot of ischemia. Actually, the main mechanism here was really ischemia and microthrombosis, and actually the inflammation came second. So the thrombosis is, of course, very important, as presented by the previous speaker as well. So this has to do also with the heart failure development. So those would be the mechanisms that you can actually develop heart failure post-COVID, and it's important to monitor our patients for heart failure symptoms or biomarkers, because heart failure symptoms are very similar to COVID symptoms. When you have patients with shortness of breath, it's very difficult to really see whether or not the shortness of breath is due to heart failure or maybe just COVID per se. So it's important to monitor, let's say, anti-proBNP troponin, or at least see patients in such a period of time after COVID to see whether or not they're developing heart failure. The second way of interaction between heart failure and COVID is the compensation of pre-existing heart failure. The heart failure is, of course, a very important risk factor for worsening of the disease, actually. And you can see here the main mechanisms. As any infection, it has to do with lung disease, also renal impairment, and also there is increased metabolic demand and thrombotic activity. Even without the direct cardiac injury, these mechanisms would be enough. And you can see here, maybe in a more schematic way, there is increased demand. Also, there is a possibility of Takotsubo, stress cardiomyopathy, ischemia, and there are many mechanisms that actually contribute to this. So if you have pre-existing heart failure, it's very important that you act early and try to prevent the worsening. So this is just a general structure of how to treat patients with decompensation of heart failure here, if they are not actually requiring inotropic support, which may be the case in many patients. So in this case, those patients have especially high risk, and they need to be taken care of even more aggressively. So when you treat, or when you want to treat COVID infections, there's a lot of interaction with pre-existing heart failure drugs here, and this has to be taken into account when you have a patient with chronic heart failure coming in, and then you treat him for COVID. There may be increased levels of beta blockers here, digoxin, ivabradine, which can give a risk to bradycardia, and you have to adjust or discontinue medications in order to do this. So this is something that also needs to be taken into account. How do you manage patients? Now you have a cohort of patients actually with heart failure, which may be a heart failure because of other reasons, or it may be worsening of heart failure post-COVID, or even, there is a risk of developing heart failure because of increased coronary artery disease or arterial hypertension post-COVID. We have seen this also nicely in the previous presentation. So how to manage them, really? There was some controversies with regards to ACE inhibitors. However, they have been really clarified. So those are the recent guidelines for managing heart failure in chronic heart failure from the European Society of Cardiology. And you can see here the basis is actually ACE inhibitors or sacubitril/valsartan, beta blockers, MRAs, dapagliflozin or empagliflozin. Those will be the ones that you really need to take into account, and also later on device therapies. So as seen here, the guidance actually emphasized that there is an importance of introducing all four drugs early on, because they have a combined effect that actually improves the outcomes in every way. So even though you have a lower dose of each agent, it's important to try to introduce this. And this also goes for heart failure patients in post-COVID era. We have to approach them the same way, even though we don't really know the effects of all these drugs on patients post-COVID, but still, since those have been drugs that have been also proven to be working in all kinds of ischemic heart failure and patients post-myocarditis, it seems reasonable that actually we want to introduce them also in patients with post-COVID heart failure, or the ones that had the compensative heart failure because of COVID. Later on, of course, you can consider other therapies like device therapies and other agents, but those would be the 4 drugs that you really need to take into account and see whether or not you can introduce them. So is there any difference with regard to heart failure management in the post-COVID era? Yes, of course. I mean, the guidelines are general ones, but still there are patients that really decompensate more and you have a severe heart failure. So you have to consider temporary mechanical support early. Of course, anticoagulation is very important, as seen before. You have to continue the drugs that the patients have been taking before, because if you discontinue them, it will significantly worsen their clinical status. So this controversy has been cleared. So if the patient has taken ACE inhibitors before, you should continue with ACE inhibitor therapy. Also, it's important to see drug interactions. This may be especially important in patients that have been really transplanted or the ones that are waiting for transplant. And of course, you have to take care also of right ventricular function, because this may be a different problem as in other heart failure patients, because we do not see right ventricular dysfunction so often in general heart failure. But here, because of the lung disease, the right ventricle is really under stress, and therefore right ventricular failure is more important. And the sad thing is we don't really have drugs to treat directly right ventricular failure, and it's very important to have euvolemia in this case, so really to see whether or not you can increase the dose of diuretics to improve the function of right ventricle. Generally speaking, there have been differences in management of heart failure patients in the COVID epidemia. One thing that has been also been increasing significantly is actually the use of telemedicine, because if you have a patient, let's say post-COVID, it's very useful to be able to give him some sort of home monitoring device, either blood pressure or just weight check. Or, I mean, ideally, it's also with the oximeters and ECGs, which is something that we have been doing recently a lot, and we have seen that this has been decreased. This has decreased the number of outpatient visits for heart failure, because of course there is limited cardiac testing available, there is limited outpatient resources available, and it makes it much more difficult if you're post-COVID to actually go and attend a heart failure outpatient clinic. So I think, the increased use of telemedicine could also help with titration of the drugs, and if so, could also, enable us to have a better follow-up of patients long-term post-COVID, because we have seen that heart failure is not necessarily an acute event post-COVID, but it develops months later, and therefore you have to be careful to see and to treat it early, and telemedicine may be a good way to really do this. So with this, I would like to stop my short presentation and thank everybody for your attention and your kind invitation. Thank you.
Hello, everybody. May I proceed?
Unfortunately, we cannot hear what's going on. That's the interpreter. Well, somehow the master of ceremonies is gone.
Yes. May I proceed my lecture? Yes. Yes, I think. Can you hear me? Yes. Yeah, okay. Thank you. Mr. Chairman, dear colleagues, ladies and gentlemen, it's my great pleasure and honor to participate in this nice symposium, and many thanks for the kind invitation, as well as thanks for your efforts to organize such a nice congress. I will also continue with the relationship with the COVID-19 and the heart, and let me do my thoughts, my experience, something special or unspecial we already heard. Coronavirus are viruses that are causative agent of common colds, and we already well known to previous recent outbreaks due to coronaviruses, SARS at the beginning of 21st century in Asia with about 8,000 cases and about 10% deaths, and the MERS about 10 years later, mostly in Saudi Arabia, but also in some other countries, especially in Middle East, with 2,050 and 500 cases and about the same count of deaths as in SARS. So now we're faced with COVID-19 is an emerging viral disease due to a new strand, very well known SARS-CoV-19. I will start with this nice thought by Michael Levitt, who said that everything we do before a pandemic seems alarmist, everything we do after the pandemic will seem inadequate. So we already also know types of 7 or more human coronaviruses, 4 normal, 3 or more novel or unnormal, and especially focus on alpha, especially on beta, gamma, but also delta, epsilon, we will follow up. There are a few tips and tricks, fakes, false news, very connected with the new virus, as Donald Trump named it coronavirus. Then only Asian men get coronavirus based on the situation that main population from Asia may have higher numbers of ACE2 receptors on type 2 alveolar cells, but other studies refute this, and we could say or conclude in this case that if any case, clearly everyone with ACE2 receptors is susceptible, and we don't have to be male or Asian to be infected. So also some fake or false news that this virus was predicted almost 40 years ago, also in Wuhan labs, as a new, very potential biological weapon, and now where we were almost 20 months ago, severe pneumonia through the globe be on the table. It connects, some people connected with old information, but of course it's another false or fake news, as well as the respiratory viral panel test for this, a lot of tests for viruses, claudommonia, mycoplasma, but it does not test for COVID-19. And my favorite one, that coronavirus came from beer, from Corona, or for Desperado. Of course, I think we will be very bored that it will be through. I think with this equipment, we already know how to live and how to face. It's a practically way of our life almost 2 years ago. But I would like to share or to show a very important connection and relationship between a patient with the COVID-19 and some kind of cardiovascular involvement. And we heard important message from the beginning from Wuhan, comparison of the impact of existing cardiovascular disease and acute COVID-19 myocardial damage as outcome. We already so have seen this from the Boyan's presentation, phase 1 to phase 2 to phase 3 with the hyperinflammation stage, or direct viral damage, or indirect through the immune inflammatory response, or a cytokine storm, or cardiometabolic mismatch, or RDS hypoxemia, which could lead to myocardial damage, or endothelial dysfunction, plaque or instability or a rupture, thromboembolism, which could finally clinical stage lead to deep vein thrombosis or pulmonary embolism, stroke, heart failure, acute coronary syndrome, complex arrhythmias, or myocarditis or pericarditis or combination. So pathophysiological elements could lead to acute coronary syndrome or acute myocardial infarction, complex or malignant arrhythmia, and heart failure. We already heard from Bojan in his excellent presentation. But we also had a very pragmatic and very potent tool in these hard times with anti-proBNP and troponin T or E biomarkers, better known as a marker of acute coronary syndrome or level of heart failure, but in this case, very potential tool to follow up the situation in our COVID-19 patient in respect to cardiovascular damage. There are shown a direct association of an increase anti-proBNP biomarker level and with malignant arrhythmias, and also an increase in troponin I, high sensitive troponin E levels, which could suggest a myocardial injury rather than presence of chronic cardiovascular disease as the possible cause of mortality in COVID-19%. If we compare a patient with existing cardiovascular disease and acute COVID-19 infection with a high level of high sensitive troponin, the mortality is really very high. It's about 70%. If a patient don't have a previous cardiovascular disease, but has acute COVID-19 infection with increased level of troponin, the mortality is twice less, but still very high, about 37%. If we have a patient with existing cardiovascular disease and a normal level of troponin, mortality is about 13%. And if we have no cardiovascular disease and normal troponin, the mortality is about 7%. Also, there are a few studies which could, where we have seen very nice outcomes of cardiovascular magnetic resonance imaging in patients who were recently recovered from coronavirus disease. We could have some message between this relationship regarding of acute coronavirus infection and cardiovascular disease, that cardiac necrosis biomarker troponin should be monitored regularly, especially in patients with previous cardiovascular disease and acute COVID infection. We think that it is very useful method of risk stratification. With this tool, we would be able to identify the most risk patient, especially in follow-up with therapeutic approach, including, of course, treatment in intensive care. And we could disagree on some expert thoughts about which time is optimal to determine the basal value, or to try to have to get some consensus on further dynamic. Is it to check every 8 hours daily, every day, or every few days, or some combination, for example, every 8 hours in really acute phase in intensive care? If we compare the mortality rate by age due to or in respect to comorbidities, it's about 10% with the cardiovascular disease comorbidities, 7% with diabetes patient, 6% with chronic respiratory disease, hypertension, and cancer. But patients with COVID-19 infection who developed respiratory failure or septic shock or some dysfunction of organs, the mortality rate is really high. It's about 15%. So from the beginning, we start to be active that there are no only COVID-19 infection as a global problem, but also try to make some connection with the cardiovascular disease and the first time with the comorbidities which are so close relationship with the coronary heart disease, like hypertension, like obesity, like diabetes, and as well as potential consequences on a normal health heart, especially in a possible way going to heart failure or acute inflammation of myocardial. So we introduce in a very early period the post-COVID cardio ambulance in our institute and introduce routine tests, troponin E, NT-proBNP, high sensitive CRP as a good biomarker, not only in inflammation, but also in the process of atherosclerosis, atherogenesis, vitamin D, because on data shown that it slightly decreased the level during the COVID infection, and the D-dimers, and of course the non-invasive test like echocardiography, 24 hours ACG monitoring, ACG blood pressure monitoring, Doppler artery and vein, and if necessary, Doppler of carotid arteries. In our data set, about 1,000 post-COVID patients who tested about approximately 1 month after infection stop, we saw about 10% or increased level of middle or high level troponin E, and as well in 15% increase level of NT-proBNP, fibrinogen about 8%, D-dimers about 8%, which is not correlate with the clinical consequences, mean deep vein thrombosis or pulmonary embolia. Vitamin D decreased in most than 16%. HbA1c as a measure of 3 months level of glucose in the curve, about 4%, and high sensitive CRP we saw increased in about 15% of our 1,000 patients. So we already have seen about 2-5% of myocarditis or pericarditis or combination. 24 hours ACG monitoring in about 8% was with complex arrhythmia with a lot of ventricular premature contractions, supraventricular contraction, or de novo atrial fibrillation, as well as about 10% of our patients have some disturbances in blood pressures, which they don't have arterial hypertensions before the COVID infection. In about 2%, which is, as I previously said, it's not in the same line as level of D-dimers. We saw deep vein thrombosis or pulmonary pulmonary emboli, and no consequences on carotid. Greetings from our Cardia post-COVID theme. We are in the follow-up process, follow-up these patients, and of course recruiting a new one. I could say or have to say that patients with heart failure, we have agreement with clinical hospital center, so they are immediately go to clinical hospital. So I haven't shown data for heart failure. Thanks a lot for your attention.
Distinguished colleagues, thank you very much, Professor Kristasic. Thank you for your attention to troponin. Now we have a lot of questions about troponins in our chat. I have to admit that we have a ton of questions from our audience. We'll try to answer them because more than 450 people are attending this particular symposium, and no wonder they have so many questions. So for the next presentation, I ask Mikhail to get the floor. He will be talking about the prognosis and the conservative treatment of chronic kidney disease and post-COVID syndrome. Let's review the cohort of patients who unfortunately couldn't survive the infection, who died throughout the treatment, and we will see that among those patients, there are pretty many patients with chronic kidney disease, stage 4 and 5, 3 even to 5. Most of these patients have chronic kidney disease in medical history. Those ones who could not survive the infection. In 77% of cases throughout the treatment, we registered the acute kidney dysfunction and damage. And those ones who survived, in 15% survived patients, we also detected acute kidney damage, and which was proven by lab tests. If we review the patients with 3rd to 5th CKD and compare it with the CKD stage 1 to 2, then we see that, unfortunately, the higher the stage, the higher chance of mortality. The higher the stage, almost in 35% of patients with stage 3 to 5 in CKD could not survive the treatment. So patients with CKD stage 3 to 5, they most commonly have the high blood pressure, they have the diabetes mellitus, and most likely these patients will develop acute kidney disease. So CKD, how the COVID-19 infection and how it affects the CKD. We see that the anemia, thrombotic microangiopathy, the disseminated intravesicular coagulation, cytokine storm, and quite often the cardiac insufficiency also develops in these patients, which makes it more complicated to treat such patients, especially if they develop acute kidney dysfunction. If we review major registries on patients with COVID-19, then we'll see that CKD in these patients are critical risk factor for severe type of the COVID-19. If we follow the diabetes, if we follow the patients with cardiovascular diseases, with the respiratory diseases, we will not see that many mortalities in comparison with the patients who unfortunately has CKD. So CKD patients with COVID-19 have a higher chance for mortality. Of course, other comorbidities like diabetes, like obesity, only aggravates the overall condition in patients suffering from COVID-19 that also have CKD. So these are risk factors to COVID-19. Major study that included 17 million adult patients in England who suffered from COVID-19, almost 11,000 deaths they registered among these 17 million people. Most of these patients were on the dialysis, had organ transplantations, hematological malignancy diagnosed more than 1 year ago, and so on and so on. You can read them on the slide. According to this study, what are the most severe type of the patients? These are patients that are treated mostly in intensive care unit. For the 14th day, patients that are not suffering with and from CKD, about 14% of such patients or 40% of such patients die if they have CKD. What happens to the patient on the 28th day in intensive care unit? We again see if patients do not have kidney disease, they have significantly better chance to survive comparing to patients with CKD that also receive kidney replacement therapy. So what happens to the patients with the kidney diseases, chronic kidney diseases, after they endured COVID-19? Survived people with COVID-19 who had the episode of acute kidney damage. In 32% of cases, they do not restore the initial kidney function within at least 21 days after they were dismissed from the hospital. And quite often, this acute kidney trauma turns into the acute kidney disease. And patients with the acute kidney disease were compared with the cohort of patients that also had COVID-19. So as for the EGFR, the function aggravates, and patients with COVID-19 and CKD, they have 2 times higher risk to lose the kidney function. This is the data from the European registry, Active, which is maintained by Alexander Artunov and Eurasian Association of Physicians. They have this unique scientific project, indeed truly unique. And if we review various registries, the British one, the Chinese one, the Italian one, and look at the Eurasian registry Active, then the dissemination and frequency of diabetes mellitus and CKD in patients that suffered from COVID-19 is about 17 and 7.5%. In British registry, the CKD is registered a bit more often, in China less often. I think that mainly spins around the age groups of the patients that are being included into the registry and life expectancy. We know that the life expectancy in China a bit shorter than in Italy, and it has a particular patterns of dissemination of the infection. If we look at the registry Active and consider the spectrum of pathologies that were registered among deceased patients, and according to the registry, about 250 patients perished, we see that every fifth patient suffered from the CKD. As for the mortality factors, among patients who were hospitalized with COVID-19, I think you will not be arguing with the figures. The higher the more severe stage proven by CT in lungs, of course, showed higher percentage of mortality. The lesser lung tissue was affected, the better chance for survival was among these patients. So as for the CKD, it was quite disseminated among the patients. So it was detected quite often in the patients that survives COVID-19 and who didn't survive it. So we can say that CKD is a very significant risk factor for patients in post-COVID period in the mortality sense. So on the left, we see the bars for the admitted patients, and on the right for the non-admitted patients, out of patients. So we see the 3A stage in hospitalized patient was seen in 18.5% of chances. So basically we can say the more severe or the highest stage of CKD was, the higher chances for hospitalization were in any patient who was infected with COVID-19. This chart depicts the mortality in the acute period depending on the CKD and age group. So patients on the GFR. So unfortunately, the older were the patients, if they were older than 60, the higher chance of mortality was detected among them. If we see that the GFR was dropping down, note the fourth stage of CKD were among the survived and died person was in 8-fold difference. So new cases of chronic pathology depending on the initial function of kidneys. So Alexander has mentioned already in his presentation that so if the initial kidney function was poor, then the arterial hypertension was quite common problem. So it was seen or detected in patients 2 times more often. As for de novo CKD, then it was also detected in other patients who suffered from COVID-19. The same we can say about the T2D, type 2 diabetes. If it was detected de novo, then most likely it was detected in patients with lower kidney function. In 6 months, the arterial hypertension figures, the arterial hypertension picture has changed in the patients. They also developed rheumatological signs. As for the mortality, unfortunately, the kidney dysfunction throughout COVID-19 that was diagnosed also with the creatinine levels. The higher creatinine levels were, the higher mortality risks were in these patients. CKD was a significant risk factor for patients within the next 6 months after the COVID infection. As for the acute kidney damage, then it was no longer detected. The signs of acute kidney damage was not detected after 3 months in post-COVID period. So acute kidney damage had caused a higher chance of so-called composite outcome. So in 3 times, the signs of acute kidney damage increased the level of composite outcome, which was again increasing the chance for mortality for such patients. This is all from my side, and thank you very much for your attention. Michael, thank you so much. I do hope that you can hear me. Thank you very much for your presentation, and we are moving to Q&A session. We indeed have a tremendous number of questions. I'll try to divide them and at least pose one question to each speaker. Please use the shortest possible answer, otherwise we'll not be able to answer all of the questions. So, the first question. We know that there are different modes of therapy. With remdesivir, hydroxychloroquine is no longer used because it is causing acute kidney damage. But other drugs, can they cause kidney damage, acute kidney damage? Yes. These were not comparative studies. I have not seen the protocols where they would compare the various frequency of acute kidney damage in these patients, but such studies have been conducted. So, and yes, there are studies that study the influence of the various drugs on such products. Professor Goran, the question is to you. If we see the troponin increase in post-COVID period, could this increase in troponin levels can cause the negative outcome? Okay, Professor Sergorovich has disconnected with us. And I will pose the question to Valery. Goran? No, Goran. Then the question about the virus neutralizing activity and the antibody level. Shall we even bother to detect the antibody level? Well, currently we need to detect what we have. Still, we see and try to understand what particular antibodies are neutralizing. Unfortunately, that doesn't happen as fast as we would like them to. There are many studies on IgM, and it's proven that they are neutralizing virus pretty well. Their role in virus neutralization is a major one. So with that in mind, we know that there is an RBD domain, and the most common antibodies are being detected within this domain. And we know already that these antibodies have the highest neutralization activity. So as for the RBD based antibodies, they have the highest chance for neutralization, the highest activity in neutralization sense. So a quick question is, so what about the vaccines? Can they actually cause the thrombosis? Yes, for AstraZeneca vaccine and a few more vaccines, they we don't know if they can cause, but this is a very rare complication. And we know that there is 1 to 5 cases. In theory, it's possible that this is a very rare chance to develop the thrombosis, so it is not a contraindication to vaccination. Even patients with the that are prone to thrombosis, this is not the reason to skip the vaccination. Next question. This question is to the Professor Boyan-Rurtovits. On the anti-myocardial antibodies, shall we detect the level after COVID-19 if the patient has complained, or if the patient has or developed CKD, then it doesn't matter what caused the CKD? Well, I'm talking about the anti-myocardial antibodies. Shall we bother and detect them in post-COVID period?
I'm not sure whether or not the anti-myocardial antibodies would add to the therapeutic effect. I would only do this if you have a case of fulminant heart failure, like a fulminant myocarditis. If not, it's difficult really to treat, because if you have acute myocarditis, then you can treat this with immune modulation, plasmapheresis, and stuff like that. But in the chronic phase, you cannot target this. So I think at this point, I would not do it in the chronic phase.
Thank you so much. And one more question, quick question, also to you. So what are the predictors to form CKD? What shall we consider in post-COVID phase? Let's say the patient suffered from COVID-19. So the practitioner, the GP, what has to be attentive to expecting that this particular patient might develop CKD in the nearest time?
So as shown in a presentation of Professor Krstatic, one of the things is important is to measure troponin series, and the other one is anti-pro-BNP if possible, because it's difficult based only on symptoms, because people have dyspnea one way or the other. So I think that's the easiest way to stratify patients, to measure anti-pro-BNP and troponin.
Thank you. So, and BNP and pro-BNP detection. Thank you so much. Professor? Batushkin, the question is to you. So, shall we use colchicine to protect the kidneys? Do you have anything in the study for COVID? I'm very skeptical about colchicine. There are recommendations that suggest to patients with rheumatology disease to give them the colchicine, but with very low GFR, less than 20 per minute, I would not prescribe them to patients with CKD because it could cause toxic reactions. For sure, this is not an answer to any disease. I'm sure that in Moscow and GU, they also considered the application of colchicine, but I think we need to run additional studies, deeper studies, to clearly answer this question. Thank you so much. The question about the patient, particular patient with ischemic heart disease, with the tele and medical history with diabetes. So after the vaccination, he develops the progressive myocardia, and I would not probably see that as the complication from the vaccination. I would say that these two events cannot be correlated. I would not correlate vaccination with this myocardia episode. I never actually met any other complaints on the fact that vaccination can cause the de novo cardiac angina. So the question about the N protein, shall we try to develop the immune response to N protein? We know that N protein appears only when the virus is replicating. This is a great question, of course. And the global society believes that neutralizing antibodies are mostly being synthesized in response to N protein. Yes, currently we have a few test systems, and we detect the antibodies to N protein, but mostly this is reasonable for vaccinated patients who were in contact with the virus itself, only for these cases. The vaccination, so I'm talking about the RNA based vaccines, not the full scale vaccines like Covivac, because they have the virus, and of course to the N proteins in this virus, the antibodies will synthesize. But in Sputnik V, we can surely say that For those patients who were vaccinated and who were in contact, they can be reasonable. The question of Professor Goran. So
Yes.
the question about troponins. Patients in post-COVID period, if we see that they had one spike of troponin, and when it goes back to norm, how can we explain that, not knowing the clinical picture?
Not only in clinical. Thank you for. I'm sorry, I have to screen off my screen for a moment because I have emergency call with my hospital. I'm on. So it's very interesting because we follow our patient about 3 or 4 weeks after stopped infection. 2 weeks of infection, then free another. It's about 5 to 6 weeks after the infection. I think we could try to explain due to prolonged inflammation, and especially in patient with myocarditis or myopericarditis, we saw more this combination than isolated myocarditis, which we practically objective in this period because of prolonged symptoms like shortness of breath, some slightly chest pain, intolerance of activity or something like that. I think because as you have seen, it's mostly in the middle period of increased level of troponin, very little, less than 1% high level, and practically more than 19% was normal in 5 to 5 weeks after the start of a COVID infection. Maybe Professor Vertovec could add something. It's something that myocarditis and myocarditis. It's the symptoms which could lead to heart failure, especially if they previously have cardiovascular disease or a previous heart failure patient.
Yes, thank you. I agree. We have discussed this also previously, that the troponin may be a very good marker, and antibodies, we do this if there is a case of progressive heart failure or myocarditis, so we can treat this directly. So in any case, as you have shown, the troponin levels that are elevated are a very good prognostic marker, so it should be monitored regularly. So I fully agree. So thank you.
Thank you. I also have one question to Vasily, to Professor Shustov, as well as Boyan. What are your opinions, or what is your opinion about some preventable give of DOACs or antithrombocyte agents or acid in the case of patients with potentially higher risk of prothrombotic possible event? What do you think? So we have some cases in our hospital that doctors recommend DOACs in a few days after the vaccination. How it's opportune, how it's safer, or do we have some attitude on this?
I will ask all the colleagues to answer this question, because this question was posed at least 5 times in our chat. So the audience would like to know the answer. Who would like to begin? Shall we use anti-aggregants or anticoagulants in patients in vaccination as a prevention in post-vaccination, in early phase of post-vaccination, in early stage?
Especially with patients who potentially could have a higher risk, or in anamnesis possible deep vein thrombosis before. Dr. Shustov, maybe you can.
I probably will talk as the lab expert, not as a clinician. I would agree that, yes, to some patients in the high risk group, I would prescribe such medicines, because in my opinion, it's best to prevent than to treat later on. And we will not see the crisis in such patients. So it's best to try to prevent on the early stage. Yes, we might not see the side effects, but I would say it is reasonable to do so, especially in patients with high risk. I've never seen thrombosis in post-vaccination period. I think we need to consider the special risk group of patients and prescribe them anticoagulation therapy in the early stage of post-vaccination. I think this is a very small group of patients, but I think we need to detect them and form. And I think this world has never seen such major vaccination in the globe. Professor Turtovich, Professor, I'm
Okay, in general, I have no experience, of course, but in general, I would not recommend to give NOACs after vaccination to everybody, because the risk of events is really low. I would consider this mainly in patients post-COVID. So when you have a COVID infection, then it's a different story, I think, because you have like increased prothrombogenic risk. Of course, I am not aware of any data on this particular population, but if you had, let's example, heart failure patients that are at risk anyway, and then you get COVID infection, then yes, I would consider this, but not routinely post-vaccination. I don't know. I don't think so. Currently, we cannot say that it's any different because it's primarily due to myocarditis. The only difference may be with microthrombosis, because this is something that is not typical of the heart failure before. So that's how, when you manage this, you have to take this into account and start the anticoagulation, I think, early in these patients, and as opposed to other patients with heart failure when the thrombosis are not as important.
I will repeat the question and translate the answer of Professor. So in the sense of myocarditis, it's the same, but as for the microthrombosis, it is probably the different type of cardiac insufficiency. It's important to begin the anticoagulation therapy as early as possible, but it calls for the additional studies.
Coronary heart disease that develops.
And the question is to Professor Katacic, can we say that ischemic heart disease in post-COVID-19 has the different structure if we compare it with the patients that did not have COVID-19?
I think we still don't know, but maybe
Я думаю, что мы так и не знаем, но, скорее всего, ответ здесь такой же, или, возможно, такой же.
Professor Vertovitz said for heart failure, the main thing is prothrombotic activity of COVID-19 infection, as well as the hyperinflammation. This is the case we try to see how is the level of high sensitivity CRP as a possible parameter of inflammation, atherogenesis, and atherosclerosis. So I think that maybe it is intensively and in a shorter period prothrombotic activity, maybe also inflammation, as well as microvascular spasm, maybe also a part of heart disease, which could be a little difference from the so-called routine or normal ischemic heart disease.
Thank you so much. We keep talking about it in various congresses. The question to Mikhail, question is to you as to nephrologist. Again, you addressed in nephrology. You asked a nephrologist questions about hemostasis. Well, can the thrombophilia influence the kidney function and actually could cause the kidney syndromes? Yes, of course. Can we see thrombosis in the kidney vessels? In patients with hemophilia, yes, but how the vaccination might influence the status of such patients, I can assume that it doesn't, but that's only because I never had a patient who would suffer from thrombosis, having hemophilia, and was vaccinated. I don't have similar experience. Probably the person who asked this question had such patients. Well, I know that the COVID-19 could cause and aggravate the kidney disease. So in best case, it's best to vaccinate. So patients with chronic heart disease, how do we treat it? Similarly to well, the same cryotherapy, and Professor Kartovits have mentioned about it, and at the plenary session, Professor Seferovic, who also addressed the cryotherapy, beta blockers, agonist of mineralocorticoid receptors, and GLT inhibitors and RNA. So I had a few more questions addressed to myself. Let me find them. Yes, correct. As for the AT-LST increased levels, that could be caused by antiviral therapy and treatment of pneumonia in COVID-19. So the Delta virus is causing myositis quite often. So the Delta virus, the strain could cause the significant increase of risks of the vascular damage, and with that increase of LAT-LST levels. So can we prevent CKD in patients with COVID-19? I would say no, we just have to follow such patients closely. I think we answered all the questions, and antihistamine drugs do not influence the post-COVID period. We answered the questions on post-myocarditis, the increased frequency of toxic myocardial hepatitis. We also answered these questions. So the patient that was dismissed from the patient had a recurrent edema of one leg without the signs of different thrombosis. So we need to look into the pelvis, her ovaries, especially if it's a female, of course. So the increase of the edema in post-COVID patients, well, I would suggest to keep the patient off anticoagulation therapy within 1 month and when the patient was dismissed from the hospital. I would like to thank every participant who joined us in this symposium. Thank you very much for your time. I do hope that we will keep meeting, discussing the post-COVID therapy, and we will, of course, discuss between experts how to vaccinate patients in these special groups with the group of high risk. Professor Kartashevich and the huge number of our audience will keep getting together, discussing other signs of CKD and the cardiac insufficiency and the in other acute diseases and chronic diseases in patients in post-COVID period. I think as soon as the data of 1 year follow-up of the patients suffered from COVID-19 will be published, we will get together once again and discuss these outcomes. Thank you very much, and see you again at other events. Thank you. Goodbye.
Thank you. Bye. Bye. Thank you.